welcome to this session. In this session, we are going to discuss about the introduction to the abdomen and anterior-abdominal wall. The abdomen and anterior-abdominal wall are clinically significant in the case of the hernias and also surgical incision. We are going to discuss about the abdomen under the following headings: introduction to the abdomen, boundaries, different layers of the abdominal wall in detail, along with the neurovascular supply. So, which help us to get insight about the different abdominal incision. So, when you say abdomen, abdomen is a part of the trunk below the thoracoabdominal diaphragm. It is the greater part of the trunk, and the abdomen is divided into abdominal cavity and pelvic cavity by the plane of pelvic inlet. It is divided into two cavities again, abdomen and pelvis. The abdominal cavity contains the gastrointestinal viscera and its glands like liver, pancreas and spleen, and also contains the urinary organs like kidney and endocrine glands like suprarenal gland and their tracts. The pelvis contains the urogenital organs and terminal part of the GIT like rectum and anal canal. So these two cavities which are divided by pelvic inlet here, and when you notice the skeleton of the abdomen, it is having the lumbar vertebrae above the thoracic cage, below the pelvic cavity, the bony pelvis, which is formed by the pair of hip bones and sacrum. So the anterior abdominal, what you see is roughly hexagonal. It is roughly hexagonal. So above it is bound by the xiphoid process and thoracic cage, laterally by the mid-axillary line, and below by the pelvic or pubic tubercle and pubic crest. When you see the right lateral view of the abdomen, the entire abdomen looks like this: a kidney-shaped cavity with an enlarged space above and below, constricted in the middle. You can see anterior abdominal wall. The inferior part of the abdomen, that is the pelvis, urogenital diaphragm and pelvic diaphragm. Posteriorly, you have a osteomusculofibrous posterior abdominal wall with lumbar vertebrae, and above it is separated from the thorax by the thoracoabdominal diaphragm. So anterior abdominal wall is only musculofibrous without any bony framework, whereas the posterior abdominal wall is musculofibrous with bony framework. You can see this entire pelvic cavity divided by this, separated from the abdominal proper by the plane of the pelvic inlet. So this plane of pelvic inlet divides the abdomen into abdominal cavity proper and pelvic cavity. And in the lower part you can see the two diaphragms, urogenital and pelvic diaphragm. Coming to the boundaries, what are the boundaries? So above it is bound by the thoracoabdominal diaphragm, below by the urogenital and pelvic diaphragm, which guards the pelvic outlet just above the perineum, and anteriorly it is by the anterior abdominal wall and its 8 layers, posteriorly by the posterior abdominal wall with its bone and muscles. The bony framework of posterior abdominal wall is formed by the lumbar vertebrae. So this is the posterior abdominal wall. What you are seeing in the middle, you are seeing the lumbar vertebrae. You are seeing psoas major and quadratus lumborum, the thoracolumbar fascia there. So above you can see the thoracoabdominal diaphragm. So posterior abdominal wall is osteomusculofibrous wall. It has bones, muscles and fascias. So that is about the posterior abdominal wall. And when you see the sagittal view of the abdominal cavity here, so this is the entire abdominal cavity. Here is the pelvic cavity, plane of pelvic inlet, pelvic outlet and pelvic cavity is here. Above you are seeing the thoracoabdominal diaphragm. Below you will see pelvic diaphragm and urogenital diaphragm. That is the plane of pelvic inlet what we have just discussed there. And why this anterior-abdominal wall is important, why you should know about this. Because in the clinical examination, we have inspection, palpation, percussion, auscultation of the abdominal wall, revealing the abnormalities associated with the different abdominal organ, just like liver, spleen, stomach, aorta, pancreas, appendix, as well as thoracic and pelvic organs. So these visible palpable deformities such as swelling, ulcer, scar, pain, they may reflect the disease process underneath the abdominal wall. That's why the anterior abdominal wall anatomy is important, and it is also used to describe the locations of the swellings, pain or scars in the anterior abdominal wall by dividing it into 9 regions and also 4 quadrants. It is divided into 9 regions by 2 vertical planes and 2 horizontal planes. So these are the 4 imaginary planes by which we will be able to locate the different organs. When you see the topography or surface area of the anterior abdominal wall, as I told, it is divided into 9 regions and 4 quadrants. It is divided into 9 regions by 2 midclavicular lines, that is 2 vertical planes and 2 horizontal planes. The horizontal planes are transpyloric and transtubercular. This is the 4 quadrant topography of the anterior abdominal wall, dividing into right upper, right lower and left lower quadrants. And this is the 9 region conception. You can see divided by the 2 imaginary vertical planes and 2 imaginary horizontal planes. The vertical planes cross through the midclavicular plane above, and 2 transverse plane, one at the level of L1, that is transpyloric plane, and one is at the level of iliac tubercle, that is transtubercular plane. So this concept of the 9 region description will help us to locate the different organs in different regions and can correlate clinically with the symptoms of the patient. So transverse plane or transpyloric plane, it crosses across the tip of the 9th costal cartilage, also L1 vertebra. Subcostal cross through tip of 10th costal cartilage, whereas transtubercular plane cross across the tubercles of the iliac crusts at the L5. And one more horizontal plane you can see is interspinous plane, crossing across the anterior superior iliac spines. So these planes help us to locate the different organs and structures correlating with the symptoms and signs of the patient. You can see that is the this is pyloric plane, this is subcostal plane, and one more is here, transtubercular and transspinal or interspinal plane. So we consider only 2 horizontal planes, that is transpyloric and transtubercular, and 2 vertical planes. These are midclavicular planes passing from the midpoint of clavicle to the midpoint of the inguinal ligament, and one more is semilunar line along the lateral border of rectus abdominis muscle that we will discuss. So these are 2 vertical planes and 2 horizontal planes dividing the abdomen into 9 regions. Why these regions are important? To correlate the symptoms and signs of patient with the clinical findings by inspection, palpation, percussion and auscultation. So the abdomen is divided into 9 regions: umbilical region, epigastric, hypogastric, left and right hypochondriac, left and right inguinal, left and right lumbar regions that you see here. So remember the 2 horizontal planes, transpyloric, transtubercular, and 2 vertical planes dividing the anterior abdominal wall into 9 regions. You can see epigastric, right hypochondrium, left hypochondrium, right lumbar, left lumbar, umbilical region, right iliac, left iliac, and hypogastric region. So these are the 9 regions. As I already told you, why these 9 regions are important, because when you see, the different region has different organs. In the right hypochondriac, you will see liver, gallbladder, part of the kidney and small intestine, whereas in the epigastric region you will see the stomach, liver, pancreas, part of the spleen and adrenal glands. In the left hypochondrium you will see the spleen, part of the left kidney, tail of the pancreas, and also the splenic flexure of the transverse colon. Whereas right lumbar you will see ascending colon and right kidney there. In the left lumbar you will see descending colon and left kidney. In the umbilical region you will see the coils of small intestine. Right iliac region you will see cecum and appendix. In the hypogastric region you will see the sigmoid colon, urinary bladder and uterus. And the left iliac region you will see descending colon and sigmoid colon. So this region wise concepts help to locate the organs. And coming to the different layers of the anteroabdominal wall, it has skin, superficial fascia, external oblique muscle and its aponeurosis, internal oblique and its aponeurosis, transverse abdominis muscle, fascia transversalis or transversalis fascia we say, extrapyramidal tissue, and lastly the parietal peritoneum. So these are the 8 layers of the anterior abdominal wall. Starting from outside to inside, skin it is thin and sensitive, then superficial fascia, below umbilicus it is divided into 2 layers, then 3 muscles, 3 flat oblique muscles you can see, external oblique, internal oblique and transverse abdominis, then transversalis fascia, also known as endo-abdominal fascia. You can notice here right from the outside, skin, superficial fascia, and you can see 3 oblique muscles here, then fascia transversalis, and you also can see the parietal peritoneum. The parietal peritoneum is the serous membrane which is lining the body wall, whereas when it covers the organs or the tubes it is called as visceral peritoneum. When it lines the walls it is called as parietal peritoneum. Just like you have already discussed about the pleura has this parietal and visceral layer. Same way the peritoneum has 2 layers. Coming to skin, it is thin and sensitive compared to the post-abdominal wall skin, and it has these Langer's lines which are horizontal in direction. The skin is sensitive, that's why before palpation you should rub your hands to make the hands warm, so that patient will not have the rigidity and guarding during abdominal examination. And it has a Langer's line which runs horizontally. It presents a cicatrix tissue or a scar tissue known as umbilicus at the level of L3 and L4. Umbilicus acts as the watershed line, means it has different neurovascular supply above and below. It is acting as a watershed line, boundary between the 2 zones with different neurovascular supply. And when you see the anteroabdominal wall here, the skin is thin and it presents a median longitudinal groove called as linea alba umbilicus, and you can see on either side of the rectus abdominis you can see these are linea semilunaris, and it shows these horizontal Langer's lines which are produced due to thickening of the collagen fibers in the dermis. And here is the umbilicus at the level L3 and L4. So coming to the superficial fascia there, the superficial fascia is a single layer, and it is a single layer, and just below the plane joining the 2 anterosepalic spine it divides into superficial fatty layer and deep membranous layer. The superficial fatty layer is continuous with the same layer in the other regions, and space between these 2 superficial fatty layer called as campus fascia and scarpus fascia is occupied by the superficial epigastric, circumflex and external pudendal vessels. So this is what you see there, 2 layers. just below the line joining to anterosupplex spine. Superficial fatty layer called as campus fascia, deep membranous layer called as carpus fascia. The carpus fascia is continuous below with the fascia lata, and in the perineum it is continuous as the colles fascia, whereas superficial fatty layer continues as the dartos in the scrotum. And in the midline here, in the midline, the carpus fascial forms the fundiform ligament of the penis. So this is about the superficial fascia. It is single layer above the line joining to anterosupplex spine and splits into two layers below that. And after the superficial fascia, you will see the three flat and oblique muscles of the anterior abdominal wall. That is external oblique, the superficial most, then internal oblique, transverse abdominis muscle. So these three muscles are located anterolaterally, whereas in the midline you will see rectus abdominis muscle, also a small muscle known as pyramidalis muscle. Where the three muscles join with the aponeurosis of the rectus abdominis, it is called as linea semilunaris. You can see that is the external oblique and internal oblique and transverse abdominis. So the aponeurosis of these three muscles, they form a retinacula around the rectus abdominis, that is known as rectus sheath, which prevents the bowing of the rectus abdominis muscle. So coming to the external oblique, it is the outermost muscle. It takes origin from the outer surface and lower border of the lower 8 ribs. The upper 4 digitations correspond with the lower 4 digitations of the serratus anterior, inserts into the outer lip of the iliac crust. The anteriormost fibers form the aponeurosis, whereas lower fibers, they reflect to form inguinal ligament, also known as Paupart's ligament, extending between the anterosupplex spine and pubic tubercle, and the fibers are directed downwards, forwards and medially. They are directed downwards, forwards and medially. Then the internal oblique, it takes origin from the lateral two-third of the inguinal ligament and intermediate area of the iliac crust. The fibers run upwards, forwards and medially, upwards, forwards and medially, whereas the fibers of external oblique were opposite. They were running downwards, forwards and medially. They are just like the external and intercostal muscles, running in opposite directions. The anterior fibers form the aponeurosis. And coming to the transverse abdominis, coming from the lateral one-third of the inguinal ligament and inner lip of the iliac crest, the posteriormost fibers insert into the lower 4 ribs. Anterior fibers, they form the aponeurosis and insert into linea alba. So these three muscles have contribution in the formation of rectus sheath. The internal oblique will divide into two layers, anterior and posterior layers. So all these muscles are supported by the lower 6 thoracic nerves and first lumbar nerve, and they are involved in the retention, compression and protection of the abdominal viscera. So when you see here, all these muscles, they form the aponeurosis near the linea semilunaris and they cover the rectus abdominis muscle in the form of rectus sheath and insert across the linea alba, the median longitudinal raphe, white line. The next layer is fascia transversalis. It is an areolar membrane lining the inner surface of the transverse abdominis. Above it is continuous with the subdiaphragmatic fascia. Below attached to the bones like iliac crest, ligament, inguinal ligament, pubic crest, and it presents a deep inguinal ring, ½ inch above the mid-inguinal point. Extraparietal tissue is a fibroareolar loose connective tissue which separates the fascia transversalis from the peritoneum. Peritoneum is a serous membrane. When it lines the walls, it is called as parietal. When it lines the organs, it is visceral peritoneum. So these are the 8 layers of the anterior abdominal wall, and in the midline you can see the rectus sheath formed by the aponeurosis of the 3 anterolateral flat oblique ribbon-like muscles of the anterior abdominal wall. You can see rectus sheath covers the rectus abdominis muscle. Rectus means straight. Abdominis means abdomen. The straight muscle of the abdomen. It has two heads, medial head and lateral head. Medial head comes from the pubic symphysis, lateral from the pubic crest. It inserts into the xiphoid process and 5 to 7 costal cartilages. So it is the median muscle, but right and left are there covered by the rectus sheath. So it presents 3 tendinous intersection which gives the segmental contraction and power to the muscle, and also gives these pack appearance, 6 pack, 8 packs of the abdomen. So packs of the abdominal wall are due to these tendinous intersections of the rectus abdominis. It is covered by rectus sheath. And one more small muscle is pyramidalis. It takes origin from the anterior surface of the pubic symphysis and pubic crest, inserts into linea alba. It is one of the degenerating muscle and acts as a tensor of the linea alba. Blood supply of the anterior abdominal wall is by the different arteries like femoral, external iliac, subclavian artery, intercostal and abdominal aorta, by the different branches like superficial epigastric, circumflex iliac, external pudendal, inferior epigastric, superior epigastric, and musculophrenic and lumbar arteries. They supply the anterior and lateral parts. You can see there superior epigastric, branch of internal thoracic, then musculophrenic, superficial inferior epigastric, superficial epigastric, circumflex iliac branches of the femoral arteries. They supply the anterior abdominal wall, and veins follow the arteries. And I told you the umbilicus forms the watershed line. It forms the watershed line dividing the neurovascular supply above and below. So these veins correspond with the arteries, and you can also see the ventral rami of the lower 6 thoracic nerves and first lumbar nerves. So this is the nerve supply of the anterior abdominal wall. So now when you see the animation here, in the animation you can notice that the anterior abdominal wall. Why anterior abdominal wall is important? To locate the organs and also correlate the findings of the patient with the clinical examination. The symptoms and signs of the patient concerned to abdomen, they help. And anterior abdominal wall is roughly hexagonal area. You can see there, bound above by the xiphoid and costal cartilage, lateral by the mid-axial line, below by the inguinal ligament and iliac crest, pubic symphysis and pubic tubercle. So you can see this is roughly hexagonal area. So iliac crest, inguinal ligament, pubic symphysis, pubic tubercle, pubic crest is here, and in the midline you can see the linea alba and a scar tissue known as umbilicus. On either side of the rectus abdominis you will see linea semilunaris. So this is about the shape and the findings of the skin of the anterior abdominal wall. It is thin and sensitive. That's why you should rub your hands to make them warm before the palpation on the patient. So when you take out the skin, then you will see the superficial fascia. There is no deep fascia in the abdomen. Remember that. The superficial fascia is a single layer above the line joining the two anterosuperior spine. Below it has one more layer called as the membranous layer or carpus fascia that you see. That is carpus fascia. It is a superficial fatty layer and deep membranous layer, and that is the superficial fatty layer. You can see there superficial fatty layer continues with the same layer of the other regions and continues as the dartos in the scrotum, whereas deep membranous layer, it fuses with the fascia lata and continues the colles fascia in the perineum. Remember that, colles fascia in the perineum. So once you take out that, you will see the muscle there. You can see that is the linea alba, where all these 3 anterolateral flat oblique muscles unite, covering the rectus abdominis in the form of rectus sheath. That is the external oblique muscle. Then you will see internal oblique. This is internal oblique, directed upwards, forwards and medially. And then you can see that is rectus abdominis in the median zone of the anterior abdominal wall. That is transversus abdominis muscle. So these three muscles are there along with the rectus abdominis. They act as a musculofibrous shield to the abdominal viscera. So skin, superficial fascia, external oblique, internal oblique, transversus abdominis, then fascia transversalis, and here you can see the abdominal viscera there, gut tubes and all. So these are the different layers of the anterior abdominal wall. What you can see there, skin is there, superficial fascia, below the line joining to anterior cephalic spine, superficial fatty layer and deep membranous layer, external oblique, internal oblique, transversus abdominis muscle there. So these muscles act as the musculofibrous wall. So they are involved in compression, retention of the viscera, and also protection of the abdominal viscera. That you can see the glistening layer is parietal peritoneum. There is greater momentum, what you see along the lower part of the stomach, greater closure of stomach. So these are the different layers. And when you come to the muscles in detail, the external oblique muscle, it is the flat oblique muscle taking origin from the outer surface and lower borders of the lower 8 ribs, that is rib number 5 to 12, and runs downwards, forwards and medially. The posterior border is free. It forms the boundary of lumbar triangle. The upper 4 slips will correspond with the lower 4 slips of the serratus anterior. The posterior border is free, and some of the muscle inserts into the outer lip of the ventral segment of iliac crest of the hip bone, and you can see there, that is the attachment, that is the iliac crest inserting into the outer lip of the iliac crest, and remaining fibers, the lower fibers, they form the inguinal ligament. And you can see here the muscle becomes aponeurotic, that is the inguinal ligament, marking as the junction between the anterior abdominal wall and front of thigh. You can see there is a superficial inguinal ring, defect in the external oblique aponeurosis, the outlet of the inguinal canal through which spermatic cord and round ligament of uterus pass in respective sexes. So the external oblique along the linea semilunaris becomes aponeurotic and forms the anterior wall of the rectus sheath. Then when you take out the external oblique, then you will see the internal oblique muscle. Internal oblique is the 4th layer of the anterior abdominal wall. You can see it takes origin from the lateral 2/3 of the inguinal ligament and also the intermediate area of the iliac crest. The fibers run upwards, forwards and medially. The posterior fibers insert into lower 4 ribs, whereas the anterior fibers, they arch over and form the inguinal roof, roof of the inguinal canal. You can see there the posteriormost fibers insert into lower 4 ribs, and along linea semilunaris they become aponeurotic. Fibers are directed upwards, forwards and medially, and they arch over and form a roof of the inguinal canal and also form the conjoint tendon with the fibers of the transversus abdominis. It also gives a cremasteric muscle surrounding the spermatic cord. The cremasteric muscle and cremasteric fascia are derived from the internal oblique. Then the 5th layer of the anterior abdominal wall, that is the transversus abdominis. Here you can see that is the transversus abdominis, taking origin from the inner lip of the ventral segment of iliac crest and running horizontally. The fibers are horizontal. It also takes origin from the thoracolumbar fascia, iliac crest, and lateral 1/3 of the inguinal ligament. Internal oblique is lateral 2/3, whereas transverse abdominis is lateral 1/3. The fibers run horizontally. The posterior fibers, they insert into the lower 4 ribs there. Remaining fibers, they run towards the rectus sheath near linea seminalis. It becomes aponeurotic. The upper 3/4 forms the posterior wall of the rectus sheath, whereas the lower 1/4 forms the anterior wall of the rectus sheath, that you can notice. Then coming to the rectus abdominis, taking origin from the pubic symphysis and pubic crest, running in the median zone, inserting into 5 to 7 costal cartilages and xiphoid process. It has 3 tendinous intersection. These tendinous intersection help in the segmental contraction of the muscle, improving the power of the contraction. Remember that. So that is rectus abdominis, covered by the rectus sheath, that you can say. You can notice there. So these about the big muscles of the anterior abdominal wall, and you will also see one more small muscle, that is pyramidalis, what you are noticing there. When you see the external oblique, the lower fibers of the external oblique, they fold upon and form the inguinal ligament, that you can see there. That is the fascia lata, that is the fascia of the thigh. And here you can see that is the external oblique aponeurosis there, forming the inguinal ligament. If you zoom here, you can see that is the inguinal ligament, demarcating the anterior abdominal wall from the front of thigh. And once you isolate here, this is the inguinal ligament attached medial to the pubic tubercle, lateral to the anterior superior iliac spine, forming the floor of the inguinal canal in the medial half. So you can see that is the inguinal ligament, a very important fibrous structure there. And as you can see here, the inguinal ligament with the superficial inguinal ring here. What you can see here is superficial inguinal ring, deep inguinal ring. This is the conjoint tendon, and you can also notice the expansions of the inguinal ligament, like lacunar ligament and pectineal ligament. That is the pectineal ligament of the Cooper, and also give the reflected part of the inguinal ligament. Superficial inguinal ring, deep inguinal ring. Deep inguinal ring is a defect in the fascia transversalis. So this inguinal ligament is the important boundary of the inguinal canal, as the spermatic cord and its contents pass through the superficial inguinal ring. Testis and spermatic cord, you can see there. So this is the external oblique having a defect there. So that then when you take over the external somatic fascia, you can see cremastric fascia and cremastric muscle derived from the internal oblique, and you can notice the internal oblique here, forming the anterior wall, roof, and posterior wall in the form of conjoint tendon, that is cremastric muscle. So it is derived from the internal oblique. And When you decode the internal oblique, you can see the transverse abdominis there arching, and the entire green color what you're seeing between the deep and superficial, that is inguinal canal, that is inguinal ligament. So these muscles form the different boundaries of the inguinal canal here that you can notice. We'll discuss about that in detail in the next video. Now coming to the dissected specimen of the external oblique. Here you can see external oblique coming from the lower 8 ribs, then running downwards, forwards and medially. You can see there the serrated slips. Upper 4 correspond with the serratus anterior, and you can see here the posterior most fibers here having these serrations from 8, 9, 10, 11, 12 ribs, and fibers are running downwards, forwards and medially towards the linea semilunaris. You can see forming the fibrous aponeurosis there, and they form the anterior wall of the rectus sheath. And in the lower fibers they form the inguinal ligament. So inguinal ligament act as a demarcation between the anterior abdominal wall and front of thigh. When you see the fibers here, they are directed downwards, forwards and medially, but the posterior most fibers, they are free and form the boundary of lumbar triangle, and the fibers insert into the outer lip of the iliac crest. You can see there, these are posterior most fibers, free. They are free and form the boundary of lumbar triangle. Now coming to the internal oblique, you can see there it takes origin from the lateral 2/3 of the inguinal ligament. You can notice there, and also from the intermediate area of the iliac crest, and the fibers run upwards, forwards and medially. You can see there fibers are running upwards, forwards and medially towards the linea semilunaris. You can notice there they take origin from the inguinal ligament and iliac crest, insert into the lower 4 ribs and form internal oblique aponeurosis. And along the linea semilunaris, the internal oblique aponeurosis splits into 2 layers, anterior and posterior. The anterior layer forms the anterior wall of the rectus sheath. The posterior layer forms the posterior layer between the costal cartilage and the arcuate line. You can see there. So abdominis muscle here, along with the rectus abdominis there. The transverse abdominis takes origin from the lateral 1/3 of the inguinal ligament and also inner lip of iliac crest. The fibers run horizontally there, and you can see there the fibers are inserting into the lower ribs and near linea semilunaris. They are involved in the formation of the posterior wall of the rectus sheath. You can see there extent of the transverse abdominis, that you can notice there. It forms the roof of the inguinal canal, and here you can see the aponeurosis of the transverse abdominis, and it also forms the arcuate line there. You can notice how it is involved in the formation of the rectus sheath. Coming to the rectus abdominis, you can see there how it is taking the origin. You can see the insertion into the costal cartilage and xiphoid process. It takes origin from the pubic symphysis pubic crest and tubercle runs upwards and having these three tendinous intersections, but here you can see the four tendinous intersection which increase the segmental contraction of the muscle, improving the power of the muscles. And when you retract, you can see the posterior layer of the rectus sheath formed by the posterior layer of the internal oblique aponeurosis and transverse abdominis till the arcuate line. That is the arcuate line. You can see there the reflection, arcuate line there. That reflection is arcuate line, where the transverse abdominis becomes anterior to the rectus sheath. That is the anterior rectus sheath formed by the external oblique aponeurosis and anterior layer of internal oblique. When you reflect that, you can see this anterior rectus sheath is attached to the tendinous intersection. When you separate it from the tendinous intersection, you can see the contents there. You can see the rectus abdominis muscle, and that is the posterior layer of the rectus sheath. So this is the rectus sheath covering the rectus abdominis muscle, and that is the linea alba, what you are noticing there. You can see now you are seeing the 7 and 8 layers. That is the parietal peritoneum, what you are noticing there. And here you can notice the fascia iliaca, the fascia of the posterior abdominal wall, and here you can see that is transversalis fascia.